A very good evening to all the respected dignitaries, senior colleagues, and all the attendees who have joined through Zoom as well as live YouTube channel. I, Dr. Neha Singh, MahaIP editor from Navi Mumbai, Raigad district, and my co-host Dr. Neeta Hatkar ma'am, who is zonal coordinator from North Maharashtra Women's Committee. Welcome you all on behalf of Maharashtra Academy of Pediatrics and Women's Committee MahaIP for today's program of Tuesday Take. Please note today's program has been allotted 2 MMC points. So requesting everyone to please type your name, city name, central IIP and MMC registration number in the chat box. Now I request our MahaIP President Dr. Hemant Gangolia sir to kindly give his blessings. Over to you, sir.
Thank you, madam. Good evening and namaste to all the respected dignitaries, colleagues on this Zoom dais, as well as the viewers on the MahaIP YouTube channel. Today's episode of this Tuesday, hearty congratulations to our Women Committee Chairman, Dr. Renu, Co-Chairman, Dr. Sonali, to do such hard work to present this 8th episode of Tuesday Takes. And we are extremely fortunate to have great stalwarts, Dr. Sudhir Sani sir and Dr. Vinayak Patki sir as a judge or experts for this today's episodes, as well as 6 fantastic speakers. And we are really fortunate and we thank them to make whatever the 6 topics they are going to speak, they are going to a crisp in the 6 minutes only. So thanks for sharing your knowledge in within 6 minutes, the various topics, as well as moderators Dr. Neha and Dr. Neeta madam. You are here to moderate this session, and I'm sure this session will enlighten us and let us proceed to the science. Wish each one an happy learning. Thank you very much.
Thank you so much, sir. Now I request Dr. Renu Guralkar ma'am, who is chairperson of Women's Committee MahaIP. Kindly unmute, ma'am.
Yeah, thank you so much, Dr. Neha. Good evening, one and all, respected Dr. Gangolia sir, Dr. Amol Pawar sir, Dr. Bhandarkar sir, and also today's experts, Dr. Sudhir Sani sir and Vinayak Patki sir. Welcome to you all to this 8 Tuesday Takes. And we are really happy to have this program under the guidance of our President Gangolia sir and Dr. Amol Pawar, who has guided throughout the last 7 programs and we successfully completed. And our 6 speakers every time were from different zones, and each one was the one who got a chance for first time on a state platform. So it was reaching the unreached. That was the aim, and it got succeeded. And the next one, that is in the October, will be the last program, that is the finale of this Tuesday Takes. The idea behind it was that for 5 minutes rapid fire, you have to give the crux of the topic, which is very, very difficult. We know that the topics are so vast, but every time, every speaker gave their best of the best, and every time we learned the wisdom pearls. And today I wish all the best to all of them, and also our moderators, Dr. Neha and Dr. Neeta. Congratulations for organizing today's program, and our co-chairperson, Dr. Sonali Shirbate ma'am. Welcome to you also. Over to you, Dr. Neha. Thank you.
Before that, we acknowledge the presence of Raigad IIP President Dr. Wankhede sir, as a Dr. Susma Save from Mumbai. She is also one of the zonal members of our Women Committee, as well as I will just request Dr. Jay to express his feelings for a minute. He is our state convener, Dr. Jay Bhandarkar. Yes, Jay.
Pallavi ma'am, kindly unmute Jay sir.
He is already unmuted, sir, ma'am. He has permission.
So probably the mic and speaker is disallowing Dr. Jay to speak for some reason or unknown reason. Let us, whenever is audible, we will hear him. Till that, Dr. Neha, please proceed. Sorry for interrupting.
Welcome, Dr. Jay Bhandarkar sir. We are very much happy to have you on our dais, sir. Yeah.
Yes, Dr. Neha, continue.
Yes,
please.
sir.
Sorry for interrupting.
We also have today Dr. Sanjay Ahir sir, neonatologist from Nasik, and Dr. Deshmukh Bhaskar Vilasrao Jaundice sir, MD Pediatrics from Baramati, are the MMC observers for today's program. Pallavi ma'am, can you see them?
No, ma'am, not yet.
Okay, they will be joining soon and we will acknowledge them at that time. The program of Tuesday Take is very unique program of Maha-IAP Women's Committee joined with association with Maha-IAP. Theme for today is investigation in pediatric practice. Unique concept of Tuesday Take is 5 minutes presentation by our esteemed speakers and then expert opinion after each topic. There are 6 speakers from all over Maharashtra and they have been allotted 6 different topics to present. Now I hand over my co-host Dr. Neeta Atkar ma'am for the further proceedings. Over to you ma'am.
Good evening, respected colleagues. Today we have got 2 experts for our Tuesday takes. Dr. Sudhir Sane sir. Sane sir has done his MD Pediatrics from Grant Medical College, Mumbai University. He has done certificate course in infectious diseases from London School of Hygiene and Tropical Medicine from University of London. Sir is practicing in pediatrics since last 34 years. He is presently director of pediatrics in Jupiter Hospital, Thane. And sir's area of interest is national pediatric practices. Welcome, sir, to the Tuesday text, and kindly opine about your opinion about the Tuesday text, sir. Dr. Sane, sir, please.
Yeah.
Dr. Sane, sir, please.
Yeah, I didn't hear I could not get what you were saying.
Sir.
So we welcome you for today's program.
Yeah, thank you.
Kindly
thank you.
share your view.
Yeah, I think it's an extremely good kind of beginning. And I'm very happy with the brains behind it that, newcomers are given a platform and they are speaking and they are sharing their wisdom with us. I think it's an extremely good concept and I wholeheartedly support it. I think very good. Thank you.
Thank you, sir. Our next expert is Dr. Vinayak Patki, sir. Sir is Chief Consultant and HOD of Pediatrics and Neonatology in Ushakal Abhinav Institute of Medical Sciences, Sangli. As well as sir is Consultant Pediatric Intensivist in Wanless Hospital, Meerut. Sir has presented more than 125 publications in various national and international journals. Sir is also on an editorial board as a member as well reviewer in almost all many national and international journals. Presently, sir is the chief editor of a journal of pediatric healthcare. Sir has major achievements like fellow of ECMO Society of India. Sir is fellow of a Royal College of Clinical Care, Critical Care and Child Health. Sir is also on a fellow of American College of Critical Care and Indian College of Critical Care. And sir is a very active member of IIT. Welcome, sir, and thank you, sir. And kindly opine about our Tuesday text, sir. Dr. Patki, sir,
Sir said this is extremely a good initiative, I think, under the leadership of our dynamic Hemant sir and Sonali madam. All this human power is working very high in Maharashtra. It's good looks that we are giving opportunity to a lot of peripheral pediatricians. Usually they don't get chance in state or national conferences, but this is extreme and will get lot of information and highlights on the topics which are day-to-day applicable for general pediatricians. That's the most important. Great thing. All the best for program.
Thank you, sir. Dr. Patki, sir, please.
Yes, I have spoken.
Thank you, sir.
Okay.
Now we'll start with our academic session. As we all know, how much important is a CBC in our day-to-day clinical practice. Dr. Vaibhavi Bharat, ma'am, she is going to speak about the ABC of CBC. Ma'am is practicing pediatrician since last 20 years at Ankur Multi-Speciality Hospital in Virar. Ma'am is secretary for PAP for the year 2022-23. She has published papers in index journals. Ma'am, welcome to the program and kindly start ABC of CBC. Dr. Vaibhavi, ma'am.
Yes, ma'am. Thank you.
I don't know whether I've filled the form or not. Whether I forgot.
There is some background disturbance somewhere.
Good evening, all. I thank Maha IAP and the Maha IAP Women's team to give me an opportunity to talk today in the Tuesday takes. My today's topic is ABC of CBC. CBC is complete blood count, which is the most sought after investigations by all of us. The components. Yes.
Madam, put the cursor on the presentation, double click kara. Yes. Okay.
These are the components of the CBC, and we'll see the components one by one through our cases. My case 1 is an 8-year-old girl child. She was brought with history of pallor since 3 years, diarrhea off and on. She hails from Rajasthan. She was treated with iron, but there was no response. On examination, she had pallor, she's stunted, she's undernourished. There's no lymphadenopathy, and the liver spleen was not palpable. Investigation-wise, her hemoglobin was 4.5 gram% with an MCV of 56 and an RDW of 25. It's a typical picture of an iron deficiency anemia. The peripheral smear shows microcytosis and hypochromic anemia. One word about the Retic count. The Retic count here is 1.2%, which is normal. Normal Retic count is 1 to 3%. But we have to do the correct. We have to see the Retic count in accordance with the hematocrit and the hemoglobin, and so we have the corrected Retic count. This is the formula of the corrected Retic count, and with this formula, we get a corrected Retic count of 0.4%, which is less for this patient. That is, it is low, indicating that the marrow is not responding to anemia. Either the marrow is diseased or does not have the nutrients to produce the RBC or the hemoglobin. This child has a typical picture of iron deficiency anemia. She was treated with iron, but there was no response. The compliance was also good. So what next? The nutritional anemia usually is from age group of 1 to 3 years. This child is beyond 3 years of age. She's 8 years of age. So we have to think about secondary causes of anemia. And our case was an iron deficiency anemia secondary to celiac disease. So our take-home message is, if a patient comes with anemia who is beyond the age of 3 years, never ever think of nutritional anemia. Always think about secondary causes of anemia. Now, a word about the relationship about the MCV and the RDW. In case of nutritional anemia, always the RDW is high, like in iron deficiency anemia, we have a low MCV. And in megaloblastic anemia, we have the high MCV. Now, low MCV occurs also in thalassemia major and in iron deficiency. So to differentiate, we have the Menzer index, that is MCV upon RBC. In iron deficiency anemia, it is more than 13, and in thalassemia, it is less than 13. Our case 2 is a 4-year-old child. She was brought with pallor since 2 months, increasing fatigability since 1 month, jaundice since 15 days. She has recurrent stomatitis. And on examination, there is pallor, icterus was present, there was no lymphadenopathy and no organomegaly. Basically, this child was treated by a general practitioner who was treating her for the jaundice. But since the fatigability went on increasing and the jaundice was persisting, she was referred to us. One word about jaundice. Jaundice usually occurs in liver disorder as well as in because of hematological disorder. When the jaundice is because of liver disorder, we ask for the history of dark urine, and the serum bili we see for direct hyperbilirubinemia. In cases of hematological disorder, there is no dark urine, and we have an indirect hyperbilirubinemia. The indirect hyperbilirubinemia because of ineffective erythropoiesis or because of hemolysis such as in G6PD deficiency or sickle cell disease. So in this child, we have a high RDW. We have a high RDW with a MCV which is 110 and the hemoglobin of 5.6. Again, the Retic count is 1.2%. We do a corrected Retic count which is low. Peripheral smear of macrocytosis and ovalocytosis. But as we go down further, we see that the WBC is 2,800, which is low, and the platelet count is 80,000. So now we are worried whether this child is having pancytopenia because the hemoglobin is low, the RBC is low, and the platelet is low. The peripheral smear shows macrocytosis, ovalocytosis, but there were no atypical cells present. The serum bili also shows indirect hyperbilirubinemia. So any child, and the Retic count was low. If it was a hemolytic anemia, then the Retic count would have been more. Since the retic count is low, that means there is ineffective erythropoiesis in this child. From this we have megaloblastic anemia, and megaloblastic anemia is the most commonest cause of pancytopenia. So our take-home message is, although all pancytopenias could be leukemia, we have to look for other causes of pancytopenia. All jaundice is not liver disorder. We have to also look for the hematological disorders. Our case 3 is a 5-month-old boy. She was brought with pallor, progressive abdominal distension, born of consanguineous marriage, belonging to the Mahar community. There was pallor present, hepatosplenomegaly, and there was no lymphadenopathy. Hemoglobin was 3 gram%. The total count was 56,000 with a lymphocytic predominance of 75%. So we have a child who has a low hemoglobin with a total count of 56,000. So are we dealing with any leukemias? A peripheral smear done, in fact, shows microcytosis, hypochromic, macrocytosis, anisocytosis, poikilocytosis, helmet cells. But there were no atypical cells, as we would have thought, with a high WBC count. But instead, we had plenty of nucleated RBCs. Now, a word about the nucleated RBCs. Nucleated RBCs are the RBCs which have nuclei, and hence the counter machine calculates them to be lymphocytes, and hence we get a high WBC count. For every 100 NRBCs, we have 100 WBCs counted. So accordingly, we have if we calculate, then our WBC count comes to be low. With the typical peripheral smear, this case is of thalassemia major. Our case 4 is a 3-year-old boy who had fever since 5 days, yet decreased activity since 1 month and complaints of leg pain. On examination, he had pallor, petechiae, there were multiple lymph nodes, and hepatosplenomegaly was present. Investigation-wise, his hemoglobin was 6.6 gram% with a WBC count of 6,700 and a platelet count of 10,000. So if we look at the CBC, our hemoglobin and the platelet is reduced. That is, platelet is reduced, but we have a normal WBC count. Now, in all cases, we have to do absolute counts. The newer counter machine also gives us the absolute counts. Absolute counts are counted with the following formula. And the ANC, when the ANC is less than 1,500, it is neutropenia. In our case, the ANC was 670. That means we have a case with moderate neutropenia. The peripheral smear showed blast cells, and the bone marrow showed blast cells of 55 to 65%. So our case was an acute leukemia. Take-home messages: in leukemias, not always the WBC should be high. The WBC can also be normal in all cases, in some cases of leukemias. Our case 5 is a 7-year-old boy admitted with dengue fever. He was afebrile, hemodynamically stable, no bleeding complaints currently. Investigation-wise, his hemoglobin was 10.6. Total count is 4,600. The platelet count is 10,000. Now, always with the current rainy season, we have a lot of patients of dengue. And with the platelet count of 10,000, even the parents are worried, and we are worried whether we should transfuse the patient or no with such a low platelet count. So for this, we have what is called as the mean platelet value. The mean platelet volume normal is 7 to 11 femtoliters. If the mean platelet volume is less than 7, it means there is decreased functioning of platelets. And if it is associated with thrombocytopenia, then the patient may require transfusion. But our patient's mean platelet volume is 8 femtoliters. That means the patient does not require femtoliter. With proper treatment, his platelets are going to increase. The second parameter is the immature platelet fraction. Normal is 1 to 7%, whereas in our patient it was 24%. Now, immature platelet fraction, normal count is 1 to 7%. It is useful basically if to see whether the child requires transfusion or no. If a low platelet count plus low immature platelet fraction, that means the child will require transfusion. With low platelet count with high immature platelet fraction, that means he does not require any transfusions. Another thing is with low platelet count, every day the patient asks us when will the platelet increase. So for this also, the immature platelet fraction is a very good indicator. Once the immature platelet fraction starts rising, if we see in this graph, the immature platelet fraction, when it starts rising, the platelet count also starts rising. So it is a good predictor for us to see whether the platelets are rising or no. When we see that the immature platelet fraction has risen, we can confidently tell to the parents, now tomorrow your platelets are going to increase, and indeed our platelet increases, and then the patient is happy with us. Now take home message. Always look at CBC. Always look at CBC cell line by cell line. Interpret all the cell line findings together. Always ask for a peripheral smear for RBC morphology, WBC differential cells, platelet number, size, and clumps. Look for parasites and also abnormal cells. And retic count. Retic count always should be interpreted in all the anemias by the corrected retic count. Thank you.
Thank you, ma'am. It was refreshing our knowledge with the different scenarios. Thank you for it. Dr. Sane, sir, please open about the or enlighten about us about the presentation and the
I
topic.
think excellent presentation, Vaibhavi. In the given time, you have really done justice to the topic. And I thought some of the important points that she highlighted was the importance of peripheral smear. So as pediatricians, we should not just ask for complete blood count, but see to it that the peripheral smear is seen by experienced pathologist or an hematologist, and that's really important. I thought another thing that was really enlightening for her presentation was, as pediatricians, we should not be happy by diagnosing either iron deficiency anemia or megaloblastic anemia. That's half-baked diagnosis. We should know the cause of iron deficiency. We should know cause of megaloblastic anemia. Remember, many a times we diagnose it as iron deficiency anemia, not even bothering why it, and that point has been highlighted very well by you, Dr. Vaibhavi. And one last point I just wanted to make is that immature platelet fraction is a good indicator, but always as pediatricians, remember that WBC count, total white blood cell count, starts rising 48 hours before the platelet starts rising. So even with our usual complete blood count, it's a good indicator when the patient is asking, when will my platelet rise? Look at the WBC count. If the WBC count has started rising, 48 hours from then, the platelet counts will start rising. And that's an important message for all of us. Thank you very much, Vaibhavi. It was excellent and lucid presentation.
Thank you, sir.
Thank you, sir. Now I hand over mic to the Dr. Neha, ma'am. Ma'am, for the next speech.
Yes, thank you, Neeta ma'am. Our next speaker is Dr. Abhijit Joshi, sir. He's pediatric intensivist at Chiranjeev Children Hospital, Aurangabad. And his topic of talk is investigations in pediatric rheumatology. Over to you, sir.
Is that visible? Screen is visible to you?
Yes,
everybody?
sir.
Yeah, very good evening. And by naming today's, that is TT, and that is on 20th of this date. So it becomes T20. And this is a shorter format. So I am just like linking it to cricket, a shorter format of cricket. And I am playing, though I am a defensive player, I am playing this hitting role. I am in a hitting role. So pardon me for any mistakes. So before going to the investigations, I would like to discuss two cases of rheumatology. In short, we won't go into the clinical discussion that this is a 2 years female, which is the picture is given. She presented with 8 weeks swelling of her right ankle, and the parents feel that she likes being carried, but otherwise remains well. The P-GALS examination, which is very important part of any rheumatological examination, has revealed no joint involvement at other sites, but she has definitely calf atrophy of the right leg. This on clinical diagnosis, definitely the girl possibly has oligoarticular GIA involving right ankle, but the history is important, physical examination is important, and initial investigations must rule out other diagnoses like septic arthritis, tuberculosis, malignancy. And always you have to have a high index of suspicion for red flags, which should include like fever, weight loss, pallor, night pains, and lymphadenopathy with bone tenderness. But in this case, obviously, the absence of all this in a well child could lead to a probable diagnosis of oligoarticular GIA. Now, if we want to work up this case, what would we ask for? Then will ask for CBC, which will be normal in this case. But whenever you have low HB, in such case, neutropenia, thrombocytopenia, think of malignancy. At the same time, when raised WBC or platelets are there, then it is underlying infection is seen. Then we should go definitely for acute phase reactants like ESR and CRP, which are commonly done, and this should look for infection, malignancy, or reactive arthritis. Should be ruled out. Then, if you are thinking of infection, then definitely we'll go for blood cultures, the serology like anti-streptolysin O, throat swab, or if required, and if you are very suspicious about septic arthritis, go for synovial joint aspiration. ANA, definitely this is oligoarticular GIA in a female child. We'd definitely like to get ANA done. We'll come to discuss about ANA later. Slit lamp examination, if ANA is positive or negative in a girl like this of this age and oligoarticular, we'll definitely have to have slit lamp examination to look for chronic anterior uveitis. Rheumatoid factor, we are not concerned about this. In this case, HLA-B27, we are not concerned about. I'm just mentioning them. Plain radiograph in early stages, it is not useful. Ultrasound maybe in the early stages if there is subclinical synovitis, but here it is obvious, so need not go for that. And MRI is indicated. So this is first case. Then second case is 9 years female. She presented with pain in legs, limping. Blood tests were done by a doctor, which were normal, but she deteriorated in a week with high fever, rash, sore throat, and joint pain. Her investigation were done like acute phase reactants were markedly elevated. Throat swab was negative. Her cultures were sent, that was negative, and she was put on obviously on parenteral antibiotic, which is the custom now, but was referred for to rheumatologist for recurrent fever. Repeat blood tests were done after some treatment went for some time, and again showed high acute phase reactants. Now this time including serum ferritin, which is also acute phase reactant, and anemia. But peripheral smear was normal. Bone marrow obviously was thought of and was done, which showed few reactionary changes. But she remained unwell with fever, rash, and another joints were involved in the form of hips, knees, hands, wrist, and shoulder. So now this becomes systemic GIA. She was given intravenous steroids, sent home on oral steroids, came back again with fever, joint pain, and rash. Now I want to add to this story that after she came back, we got repeat investigation. There was a drop in hemoglobin, there was leukopenia, thrombocytopenia, ESR dropped, and CRP was high, and serum ferritin again was high. So this led to us to the diagnosis of macrophage activation syndrome. The only point I want to stress that we should not we should not let it go. This is very important. So just after having two cases in which you can make out that bedside clinical examination is the crux for identifying the disease, and the laboratory investigations are just supporting, and there is no specific test to diagnose any rheumatological condition. Only they can just help support the diagnosis, manage treatment, and prognostication. So basic laboratory tests are done like hemogram, as madam in her previous lecture has nicely mentioned. This anemia of chronic etiology, it is normocytic or normochromic. Then sometimes in SLE, there is autoimmune hemolytic anemia associated with direct Coombs test positive. If you have total leukocyte count increase in many inflammatory conditions, so they lead to arthritis and decrease in SLE-like conditions. If there is thrombocytosis, it is like suggestive of ongoing inflammation in KD, like Kawasaki disease, juvenile inflammatory arthritis, and Takayasu arthritis. Thrombocytopenia is seen in SLE, malignancy, and MAS. So we have to think of all these conditions whenever we get such results. Then acute phase reactants are like, as I already told you, CRP and ESR. CRP is early to rise and early to fall, but ESR is a late riser, and it falls slowly. So it is a reflection of ferritin also, because that is indicator of ferritin levels. So ESR in 3 digits, always think of rheumatological disorder, malignancy, or infection. A rapid rise in ESR a rapid fall in ESR along with a rise in CRP, always think of MAS. Urine analysis, of course, rheumatological conditions, urine analysis has a good value, and early primary manifestation of SLE, enophthalial purpura, or ANCA-associated vasculitis, and sometimes secondary amyloidosis occurs in systemic GI. You have to have urine protein creatinine spot ratio, which if it is high, then you have to do 24 hours urinary protein estimation to think of lupus nephritis. Then also you have to look for RBCs per cell, urine RBCs per cell SAS. Sterile pyuria is seen most of the times in KD, and that has to be differentiated. Otherwise, if the patient goes for treatment of UTI. Serum ferritin acute phase reactant, it differentiates definitely between Kawasaki disease and systemic GI, where it is markedly elevated in systemic GI, while it is moderately elevated in Kawasaki disease. Of course, serum ferritin, if it is very high in the presence of rheumatological disorder, then think of macrophage activation syndrome. Rheumatoid factor, again, it is a acute phase reactant, which is IgM antibody or sometimes IgA or IgG, also against FC portion of IgG, and it is done by ELISA. It is a very good indicator, but it is only used for the classification and differentiation of rheumatoid arthritis. Rheumatoid factor is present in many conditions like infections or sometimes infective endocarditis or hepatitis C infection. So it should be if the only positivity does not have any significance, so should be positive on 2 separate occasions 3 months apart. Then with that, anti-citrullinated peptide antibodies, which were very significant earlier and also done in adults, but they have less value. But if they are positive in the presence of RF positive, then it is indicative of erosive bone disease. When synovial fluid analysis sometimes is indicated when you have to differentiate non-inflammatory to versus inflammatory conditions. So I beg your pardon for this. More than 200 cells, it should be more than 2000 cells. So this is differentiating. So sometimes you have to do a synovial fluid analysis to rule out septic arthritis like conditions. Muscle enzymes, of course, like creatine kinase, lactate dehydrogenase, aspartate aminotransferase, and aldolase. These are the breakage because of the breakage of the muscle cells. These are released. This creatine kinase is first to rise and fall, but the specificity is with the lactate dehydrogenase and aspartate transaminase when combined together. These are raised in multiple inflammatory myopathies. The complement cascade is important because they are also acute phase reactant. There are 30 types of complements, and there are 3 pathways like classical pathway, alternate pathway, and one more pathway is there, where the activation of the autoimmune activity that causes consumption of the platelets. So whenever you get classical pathway activation when C3, C4 are low, then you can think of SLE. While low C3 and normal C4 gives an alternate pathway. Autoantibodies is the hallmark. Like they are sometimes that is very important part of the radiology, this rheumatological investigation, where ANA antinuclear antibody done by indirect immunofluorescence assay and ELISA assay both. But indirect immunofluorescence assay is the gold standard about for that. 9 to 15% of healthy children also have ANA positivity. But ANA, the negative predictive value of ANA is very much in SLE. But along with that, if oligoarticular GI is there and if you are ANA positive, then you think of you screen the patient for uveitis because it is a very risky disorder, and you have to always think about that. Anti-DRSDN is another autoantibody which is very highly specific for SLE, and it has a indication for monitoring lupus nephritis. So you have to track the anti-DNA titers. ANCA is anti-neutrophilic cytoplasmic antibodies which are against the neutrophil. There are granules inside the neutrophil. They are antibodies against that. So there are 3 types like C ANCA, that is cytoplasmic ANCA, then perinuclear ANCA, and atypical ANCA. C ANCA is generally they rise in granulomatosis with polyangiitis, which is previously called Wegener's granulomatosis. P ANCA is seen increase in microscopic cholangitis and eosinophilic granulomatous polyangiitis, which was previously called Church-Strauss disease. Now, antiphospholipid antibodies are in the continuation of another systemic disorder like SLE or that. So you have three types of antiphospholipid antibodies: lupus anticoagulant, anti-beta-2 glycoprotein 1 antibody, and anticardiolipin antibody. So children with lupus should be screened. This APL has significance when we see thrombotic disorders in children, and when some pregnancy outcomes are like they have spontaneous abortion. This is called APS, that is antiphospholipid antibody syndrome. So coming to the imaging, this is the last part. So imaging, we have divided into X-rays. X-rays generally are not useful in soft tissue changes, but they can identify the structural damage or differentiating other conditions like trauma, skeletal abnormalities, or tumors. If you have suspicion of some other foul play like there's battered baby syndrome, then you have to go for skeletal survey. Ultrasound is very sensitive in diagnosing soft tissue swellings like tenosynovitis, enthesitis, cartilage, and bone abnormalities, and it is also useful in while giving intraarticular injection, but it requires a very lot of skill and experience, and it is very operator dependent. MRI of musculoskeletal system is very good test to conduct for diseases involving the muscles, tendons, ligament like enthesitis, these all conditions, or early stage detection of the rheumatic disorders and muscles, particularly in juvenile dermatomyositis. Of course, when certain joints are not accessible, like temporomandibular joint or the spine is involved, or sacroiliac joint involvement, then MRI is a must. But the only drawback is that the the children generally they have to have sedation for the longer scans. Today echocardiography has its importance in Kawasaki disease, where the coronary this status is seen, as well as the cardiac anomalies are seen, as well as in Takayasu arteritis. While the CT angiography and PET scan, they can see the vessel condition in Takayasu arteritis or pyoarteritis nodosa. Biomarkers, because some diseases like KD are the clinical diagnosis, there is no specific test. So sometimes NT-proBNP, that is by the N-terminal pro by natriuretic peptide. These are very increased, and that has a involvement like cardiac. This is a prognostication factor. So these are increased, and procalcitonin, they differentiate between other systemic illnesses versus the KD, and procalcitonin if are very highly increased, then they suggest the resistance to IVIG treatment. HSP, of course, has HLA-B35, which indicates its association with nephritis. JDM is differentiated on the basis of myositis-specific antibodies or myositis-associated antibodies. And last, coming to the genetic markers, JI, several HLA associations like HLA-B27 is associated with juvenile spondyloarthropathies, ankylosing spondylitis, also in other diseases like reactive arthritis, psoriatic arthritis, and sometimes they are present in 5 to 10% of the normal. So always you have to order a test in the context of the clinical presentation. So never order a test without clinical context in the mind. And SLE, 1% of the SLE cases are monogenic, and if there is C1q deficiency, then there is 90% risk, and if there is C4 deficiency, then there are 74% risk of having monogenic SLE. So always take home message is this bedside clinical examination, history taking bedside clinical examination are clue to the diagnosis of any rheumatological case, and these investigations are not to be ordered as a rheumatology panel, because it will be imprudent to advise a rheumatological panel in the absence of a clinical context in the mind. So thank you very much.
Thank you, Dr. Abhijit, sir. You have presented a very crisp and informative presentation. Although rheumatology is a very vast topic. Before the expert opinion, I would like to acknowledge the presence of our MMC observer, Dr. Sanjay Ahir, sir, from Nasik. Would request Sanjay, sir, to give his views after Dr. Sudhir Sane, sir's expert comment. Sudhir, sir?
Yeah. Thank you, Abhijit. I think it was very extensive and it is very difficult to cover rheumatological investigations. But some points that you have highlighted are importance of clinical examination, and also many a times we have to resort for serial investigations rather than depending on one investigation. I just want to add 2, 3 points here, that when as a pediatricians we are asking for investigations, ask for, if you are asking for CRP, ESR, ask it as a combo investigation, because how both of them differ with respect to each other might give you a diagnostic clue. For
Yes, sir.
example, high ESR, low CRP might
Yes, sir.
suggest SLE, and as
Yes.
you indicated that early infection maybe CRP is high, and you also elaborated so nicely about macrophage activation syndrome. I also wanted to kind of highlight again what you said, that ANA and RA factor are many times false positive in normal
Definitely.
children, and also can be elevated in certain infections, including Epstein-Barr and viral infections. So
Yes.
don't diagnose SLE or rheumatological condition depending on one investigation. And I
Yes.
think overall a very nice wide presentation. And I think that's all I wanted to comment. Thank you very much.
Thank you, sir. Thank you very much, sir.
Thank you, Sudhir sir. Now I would request Dr. Sanjay Ahir sir to kindly unmute and give his DSS.
Yeah, good evening, everyone. I'm Dr. Sanjay Ahir, MMC observer for today's meeting. I will not take a lot of time from your academic discussion. Excellent discussion is going on, and all the best to all the speakers and all the moderators. Thank you.
Thank you, sir. Now I hand over to Dr. Neeta ma'am.
Thank you, ma'am. Now our next speaker is Dr. Amarjit Wagh, sir. He is a pediatric neurologist and epileptologist. Sir is presently director of a Little Brain Center. Sir is chief editor for the Indian Journal of Pediatric Neurology. Sir has written 2 chapters in textbook of pediatric neurology. Sir has done research in infantile spasm and ketogenic diet. And sir is a faculty in national and international conferences. Dr. Amarjit Wagh, sir, his topic is neuroimaging indication in pediatrics.
Good evening, all. My slides are visible. Hello.
No, sir.
No, sir.
Sir, click on the presentation, please. We got a thumbnail view. Just click on the presentation again.
Sir, please stop the sharing, open your slides and then share.
Fine. Is it there?
No, sir.
It was working.
Sir, we
No,
can see your
computer screen. Yeah.
thumbnails. No, we can see your thumbnails or the computer screen. Just share that screen and double click on your presentation. It will show. Try it once again, sir.
Now?
Yes, sir.
Still not?
Yes, sir. Yes, sir. It is visible. And it is full screen. Please go ahead.
Yeah, sorry for the technical issues, and thanks organizers, thanks MyIP for such a wonderful concept. I'll be talking about indications for neuroimaging in pediatrics. As we all know, there are different imaging modalities. If you want to screen brain, and they start right from neurosonogram, then CT brain, MRI brain, PET scan, and SPECT scan. Each have their own fallacies and each have their own advantages over the other. Neurosonogram mainly till the AF is open, we can utilize it. But as we say, the window, it's only a window and it's not a door, so you can't see the brain as well as you can see from a CT or an MRI. CT again has its own limitations, that the radiation hazards are there. Second, only traumatic brain injury, infections, meningitis, where you have the certain, if the financial constraints are there, then these are the only 2 indications I will say where the CT is more preferable nowadays. And then the third and the most common modality of, hello, am I audible?
Yes, sir.
Yeah.
Yes, sir.
Yeah. And the third and the most important modality is the MRI brain. So today will be, since I have very limited time, today we'll be just talking about MRI brain. There are different indications for which we should investigate the child with any brain problem and should order MRI. And the indications could be epilepsy, any child with seizures. What are the indications of seizures that we'll see? Metabolic disorders, space occupying lesions, developmental delay, stroke, CNS infections, be it meningoencephalitis, bacterial, fungal, tubercular, headache, and different kind of neuropetaneous syndromes. So why in MRI in epilepsy? Because it can identify, localize, characterize subtle lesions with better spatial and temporal resolution, and that's why it has become the investigation of choice in epilepsy. What are the indications for MRI in epilepsy? Like onset of seizures at any age with evidence of focal onset in history, like focal seizures, or the EEG showing any focal changes. Onset of unclassified or apparently generalized seizures in the first year of life. This is always a confusion that in a GTC shall we order for an MRI. A child less than 1 year of age, unprovoked seizure or unclassified seizure, MRI is warranted. Evidence of a focal fixed deficits on a neurological or neuropsychological examination. Difficulty in obtaining control of seizures with first line antiepileptics, and in case of refractory epilepsy to see any lesional kind of epilepsy is there. Loss of control of seizures with AEDs or change in the seizure pattern, again that will tell that are there certain changes in the anatomy that has led to a different kind of seizure semiology. So these are the indications where we should order for an MRI, and this picture tells you almost everything. All the reasons of epilepsy can we can see here, like a polymicrogyria, focal cortical dysplasias, neurocutaneous syndromes like tuberous sclerosis, Sturge-Weber, heterotopic gray matter, cavernous hemangiomas, tumor-related epilepsies like DNET, gangliogliomas. So these kind of different sets of etiologies we can find in a child with focal seizures with MRI. This one patient who's typically showing left mesial temporal sclerosis. There is the volume loss is here with signal change. So this is a picture of left MTS. These patients, when they are refractory, can be subjected for an epilepsy surgery. So the guideline says that almost 50% of individuals in which imaging was done in localization related new onset seizures, they were abnormal. 15 to 20% of them, it was useful to find out the etiology, and in 2 to 4% provided information that potentially altered the immediate medical management. So the role is still in the newly diagnosed patients and even in the refractory seizures. Moving to the second set of disorders like metabolic disorders. This is a child 7-day-old with history of seizures. All the routine and the septic workup was normal. The routine metabolic and the septic workup was normal, and then the MRI showed this is a significant signal change, the classical signal change in the posterior limb of ventral capsule plique that we say, and that is suggestive of a maple syrup urine disease. Then the metabolic TMSG same was said, which was suggestive of a MSCD. Second, a 10-month-old child with large head and developmental delay, and this MRI is showing a typical perirolandic atrophy. It is called as a bat wing appearance, along with signal changes in the putamen or the other parts of the basal ganglia, such as giving a suggestion towards a metabolic disorder called as a glutaric aciduria. Third part is a neuroimaging in tumors like space occupying lesions. 4-year-old girl who presented with headache, walking difficulty, vomiting, and then this MRI showing a significant space occupying lesion involving the posterior fossa. The heterogeneous lesion is seen. It on contrast is highly enhancing lesion, so that is more suggestive of a pilocytic astrocytoma. Many a times just a brain MRI or MRI with contrast might not help, especially in case of metabolic disorders and in case of SOLs. So the third investigation will be a MR spectroscopy. Different peaks will guide you. That lactate peak will tell you about the mitochondrial disorders. The choline peak will tell you about the different sets of brain tumors. So just MRI, just by ordering MRI, many times the purpose is not solved. So we need to see why are we ordering it, and depending on that, we can ask for whether to go for an contrast, whether to go for an angiography, whether to go for an spectroscopy. Third set of disorders are developmental delay. Like MRI is the best modality for investigating these children. They tell you the anatomy, they tell you the myelination, they tell you the relationship of the posterior fossa as compared to the anterior fossa. They tell you about the ventricle size, they tell you about the hydrocephalus, and they many a times can point out towards different sets of reasons like IU infections or any genetic disorders. So this is a child who is having hypoplastic cerebellum. Both the sagittal as well as the axial cuts are showing a significantly hypoplastic cerebellum. These patients can manifest as an atonic CP. The term is obsolete now, but a hypotonic CP, a child with this kind of MRI, many a times that they do have some genetic association. So we can further investigate this child depending on these MRI findings. Stroke, any child, just a plain simple stroke or MRI screening might not help. So certain diffusion sequences are needed. Most of the MRI centers, they do it, but we have to be very sure that these sequences are being done. Otherwise, we can miss the stroke. This is called as the ADC reversal, that is apparent diffusion coefficient. So this tells you, this picks up the stroke very early. So ADC mapping is important, and to know for the vessel anatomy, we should go for MRI angiography. So child with stroke, not only just plain MRI with MRI angiography will tell you that whether any occlusion or any other etiologies are there. Next is the Neuropetaneous Syndrome. This is a child, maybe 2-year-old child with history of convulsions, mild developmental delay, hyperactivity, and certain skin spots like Ashleaf macules. And when this MRI was done, this is classically showing subcortical tumors, which is suggestive of a Neuropetaneous Syndrome like tuberous sclerosis. Moving to the next set is like headache in children. The SOLs, they can manifest as headache, but even in the plain headache or any child who comes with headache, shall we directly go ahead for an imaging, or what are the indications that we should consider MRI? Diagnostic neuroimaging should be considered for children with abnormal neurological examination or history that suggests neurological dysfunction. So on routine basis, MRI is not indicated, but when there is a change in the pattern of headache, when there are associated seizures, the headache is associated with some systemic illness like weight loss, on and off fever, personality change, symptoms suggestive of raised ICP like new onset headache in the early morning, or headache that is worsening with coughing, sneezing, or straining, and any abnormal neurological examination warrants an MRI. And next is a CNS infection. So imaging studies are not the means by which meningitis is diagnosed. So obviously, meningoencephalitis is diagnosis of a CSF study and the clinical presentation, but they tell you the extent of, they tell you the severity, they tell you the extent when the brain is involved. They still tell you the complications, like in meningitis, the hydrocephalus or abscess formation that cannot be picked up if we are not doing an imaging. Then CT and MRI studies in complicated cases of prolonged meningitis are usually normal. Sometimes some enhancement is there, but mainly what we have to see that what are the complications that come across, and in those cases we should order MRI in meningitis. Meningoencephalitis or plain encephalitis, MRI is warranted. The same is true for the tubercular meningitis. So neuroimaging for complications of meningitis like hydrocephalus, venous thrombosis, venous infarctions, arterial infarcts, effusions, empyemas, ventriculitis. So these complications should be kept in mind, and we can see them well on MRI. So this is a child, classical encephalitis showing temporal lobe affection, a 6-year-old child with altered behavior, fever, and seizures. This one is a 8-year-old child with history of 1 month fever, altered behavior, focal seizures. So MRI suggests a very large intensity lesion with significant perilesional edema. This most probably fitting into a tuberculoma or tubercular meningitis. Had there been the multiple lesions and no history of fever, this and the differentials will be neurocystic sarcosis. So the differentials, the ring enhancing lesions can manifest differently on MRI, and depending on that, we should classify them and should investigate and treat them further. So the last slide, how the neuroimaging is important and when should we do. It plays an important and growing role in the diagnosis and management of neurological diseases in children. Advancement in diagnosing imaging have revolutionized the practice of modern medicine. Neuroimaging allows more accurate diagnosis of certain CNS disorders and neuroanatomical differences. Observation of current practice pattern indicates that neuroimaging overuse is many times is overused, but we should be very pertinent and should be very selective whenever we're ordering for a generalized indications. And MRI helps in localization and lateralization of seizure focus in cases of epilepsy. It falls into two broad categories, like structural imaging deals with structure of the brain, and functional imaging. We haven't discussed this functional imaging part since the time is we have little time, but that's how it is very useful. Thanks all.
Thank you, sir, for nice presentation. And Dr. Sane, sir, your expert opinion, please.
I think here I can say that Amarjit is a real expert and he has got such an experience and it showed in his talk. Just one or two things from a perspective of a general pediatrician that I want to stress that, and he commented on that, that MRI is expensive as far as the time and as well as the economic cost is concerned. And MRI requires sedation. So definitely try to avoid MRI in a hemodynamically or cardiovascularly unstable patient because during MRI, it is extremely difficult to resuscitate the child. The second thing that he very nicely commented that when MRI in epilepsy, when you think of suspect localization or when there is a obvious clinical evidence of localization or you cannot rule out localization, then you do MRI. And last thing that I wanted to say is indications for neuroimaging, especially MRI in cerebral palsy. In cerebral palsy, you need to do MRI not in all patients, not because the patients are anxious, but if there is no significant history of neonatal encephalopathy, then please go ahead and do MRI because some of those, and I think Dr. Amarjit can tell us much more about that some other time, that there are tremendous differential diagnoses of cerebral palsy and which we as general pediatricians should not be missing. So ask for history of neonatal encephalopathy. If it is not there, get an MRI done. Thank you, Amarjit. It was a good and lucid presentation.
Thank you, sir.
Thank you, Sane, sir. Thank you, Amarjit, sir.
Thank you, sir. Sorry for interruption. Now, I would acknowledge as our second MNC observer, Sir Dr. Deshmukh Bhaskar Vilasrao Jende, sir. He is from Varamati, MD Pediatrics. Sir, can you unmute and give your blessings? Dr. Deshmukh, sir. Pallavi, ma'am.
Yeah, ma'am. Permission is given.
Okay, we will go for our next topic and next speaker, Dr. Pratap Pathare, sir. He is Director and Consultant Pediatrician from Siddhivinayak Children's Hospital, Ahmednagar. He has one international publication on topic scorpion sting with ST segment elevation, and his topic given is scopies in pediatrics. Over to you, sir.
Thank you very much. I will share my screen. Is it visible?
Yes, sir.
Yes, sir.
Yeah.
You have to do full screen. Full screen. Kindly full.
Yeah, it's full screen from my side.
No, sir, it's not full screen. You can stop sharing and then again share and you just go to the full screen wala PPT option.
Go to slideshow.
You may see two PPT, one open one and one other.
Yeah.
Click that. Yes.
Yes, sir.
Yeah. Okay. Good evening, everybody. Thank you very much for giving me a chance to speak here on the Tuesday Takes platform. I'm going to talk on scopies in pediatrics. It is a vast topic, though. I have tried to cover most of the important aspects. Endoscopy. The definition of endoscopy is examination of the inside of the body by using a lighted flexible instrument called an endoscope. In general, an endoscope is introduced into the body through a natural opening. The history of endoscopy. Dr. Philip Bosch, he introduced first endoscopy in 1805 and named as Lislater candle. The pediatric endoscopy came into existence nearly 170 years later. In 1800, the combustible lighting was used as a method of illumination, which was a dangerous method. After that, Thomas Edison's electric bulb quickly resolved this issue in 1880s. The fiber scopes became widely available by 1970s. In 1969, Hopkins rod lens system permitted miniaturization, and the use in pediatric and smaller children, the scopy was possible. This revolutionary system paved the way for development of the pediatric specific fiber endoscopes. The video endoscope was first introduced by Welsh Allen in 1983, and a charged coupled device allowed real-time image display on video monitors, which transformed the field and art of endoscopy. So what systems can be evaluated by endoscope? The ENT, we can do sinoscopy, we can as well do functional sinoscopy. Pulmonary, we can do bronchoscopy. It can be by rigid bronchoscope or a fiber optic bronchoscope. GIT, we have the upper GI scopy and lower GI scopy. Neurology, we can do cystoscopy, ureteroscopy. The aim is diagnostic and therapeutic. By far, pulmonary bronchoscopy by rigid bronchoscope and the GI endoscopy is the most commonly done scopy, at least for a general pediatrician. These are the most commonly required investigations. Now, diagnostic upper GI scopy. What are the indications of upper GI endoscopy? Hematemesis, dysphagia, persistent refusal to eat, persistent chest pain, upper abdominal pain, symptoms suggestive of serious organic disease where there is severe weight loss, acid peptic disease, persistent vomiting of unknown cause, ingestion of corrosives, and unexplained iron deficiency anemia. We need endoscopy for sequential or periodic diagnostic thing. So Barrett's esophagus, ulcers or mucosal abnormalities, and follow-up of sclerotherapy. What are the therapeutic uses? Removal of selected polypoid lesions, sclerotherapy or banding of esophageal varices, dilatation of strictures, placement of feeding tubes, persistent bleeding, which is unresponsive to medical therapy, of esophageal or sharp or foreign bodies or objects retained in the stomach longer than 2 to 4 weeks, button batteries ingestion, and endoscopic retrograde cholangiopancreatography, ERCP. So here is an image where there are button batteries seen, and these are retrieved by with the help of an endoscope. Rectal polyp is visible through the lower GI endoscopy. The esophageal stricture, very small and narrowed opening can be seen. Esophageal varices, and in this image we can see the ligated esophageal varices. When a corrosive ingestion has happened accidentally, we need scopy to insert a feeding tube. Diagnostic colonoscopy. We need diagnostic colonoscopy in melena, hematochezia, significant diarrhea of unknown origin, inflammatory bowel disease suspicion, evaluation of abnormality on radio imaging, intraoperative identification of a lesion which is not apparent, and rectal trauma. Contraindications of scopy, the absolute and the relative contraindications. Absolute contraindications are unstable airway, cardiovascular collapse, intestinal perforation, and peritonitis, a respiratory infection in a hyperreactive airway disease patient. Relative contraindications are bowel obstruction, severe thrombocytopenia, coagulopathy, recent GI surgery, respiratory infections, and recent food intake. So consent before scopy is important. Explain parents and the child about potential risks and benefits using an age-appropriate language. Important elements of this discussion should be acknowledged in writing and signed to provide legal documentation. So what preparation we need? So fasting and intestinal preparation are important. So fasting from solids for at least 6 hours, liquids for 2 to 4 hours. Longer fasting is needed in cases of achalasia cardia and gastric outlet obstruction. The anesthesia, American Society of Anesthesiologists, they state that children can be offered clear liquids including breast milk 2 to 3 hours before sedation. Infants less than 6 months can take formula 4 to 6 hours and clear liquids up to 2 hours before sedation. So this has been adopted from the article of American Society of Anesthesiologists, Task Force on Sedation and Analgesia. Here we can see the fasting period and the food items which can be given. Bowel preparation for colonoscopy. Small volume enemas and substituting clear liquids for milk 12 to 24 hours prior to the procedure. The safety and effectiveness of large polyethylene glycol based solutions with electrolytes which causes osmotic diarrhea has been demonstrated. Sedation. The aim of sedation is guarantee the patient's safety and welfare, reduce physical pain, minimize anxiety and maximize the potential for amnesia, control patient's movement for the safe procedure, and discharge the patient safely. Moderate sedation or general anesthesia is used. Pediatric patients, they have respiratory complications because their airway offers more resistance. Infants less than 7 months are obligate nose breathers, so they are prone to develop the respiratory complications. Children are less resistant to hypoxemia, so we have to take extra care and maintain their saturation well. So here are the drugs which can be used for the intravenous sedation: midazolam, meperidine, fentanyl, ketamine, propofol, and the reversal agents are flumazenil and naloxone. So studies have shown that propofol is the most safe drug which can be used for sedation or deep sedation. And propofol is a drug which can be used by a non-anesthetic consultant also. The equipments required are, it depends on the weight of the child. So a child as tiny as less than 2.5 kg can also undergo a scopy because of the advances. A less than 6 mm gastroscope can be used for esophagogastroduodenoscopy. The same scope can be used for colonoscopy. And for ERCP, we need a 7.5 mm duodenoscope. 2.5 to 10 kg child needs less than 6 mm gastroscope. Same can be used for the colonoscopy. The 7.5 mm duodenoscope can be used for ERCP. More than 10 kg child can undergo gastroscopy by adult gastroscope. And there is a pediatric colonoscope available from 11 to 11.6 mm diameter, or a adult colonoscope can be used. Most children weighing more than 10 kg will tolerate the standard therapeutic duodenoscope. Companies which manufacture these scopes are Olympus, Fujinon, and Pentax. There is a working channel, so we can introduce a lot of devices through a endoscope, and we can do the procedures like removing a polyp or banding or injecting a sclerosing agent. So these are the devices which can be introduced. One is injection needles, biopsy forceps, polypectomy snare, ERCP cannulation catheters, sphincterotomes, needle knife papillotome, stone retrieval balloons, retrieval baskets, graspers and retrieval devices, bipolar probe, and argon plasma coagulation probe. This is how a scope looks. So there is a umbilical cord, called as umbilical cord, where there is a guiding light, there is a water container connector, there is a air pipe. We need insufflation of the viscous before introducing the scope, electrical contact, S-cord connector, suction connector. And here is a eyepiece for looking and viewing, and the video controls are there. There is a biopsy channel from where we can introduce the accessories. We can see the cross section where there is a biopsy channel opening, light guide, objective lens, air and water nozzle. Capsule endoscopy is a very advanced form of endoscopy, which was approved by US FDA in 2003 for children more than 10 years. Can be done in infants as young as 10 months, but this has not been approved by US FDA as yet. The pros are avoids radiation and sedation. The cons are ability to swallow the capsule is a limiting factor. So here is the image of a capsule endoscope. There is a light source, color video camera, battery, a transmitter, and there is a data storage facility also there. Conclusion: pediatric GI endoscopy is evolving and provides a safe and effective diagnostic tool. Children of all ages, including premature babies, can be examined. The emerging diseases like eosinophilic esophagitis can be diagnosed. ERCP in neonatal cholestasis. The other system is respiratory, where we do bronchoscopy for retrieval of the foreign bodies. This is a view through a bronchoscope. We can see the main bronchus, and here we can see the right and the left bronchus. So this is an algorithm how you should approach a case of suspected foreign body aspiration. When a patient comes to us, if the child is symptomatic and unstable, emergency management for airway obstruction should be done. That is intubating the child and ventilating properly, bringing up the oxygen saturation. In a asymptomatic child or symptomatic child but stable child, get a radiograph done. If you identify a foreign body or the changes where there is a foreign body aspiration like hyperinflation on one side and hypoinflation on the other, go for bronchoscopy. If the radiograph is normal or it is equivocal and you have a low clinical suspicion, observe the child, treat any suspected underlying disease process if there, and follow up in 2 to 3 days. Evaluate further if symptomatic. If the radiograph is normal or equivocal and there is moderate or high clinical suspicion, get a CT scan done. They also call it as virtual bronchoscopy. If the scan suggests there is a foreign body, you can go in for bronchoscopy. If it is negative for the foreign body, observe the child and treat underlying disease process and follow up the child after 2 to 3 days. This is a setup required for the rigid bronchoscopy. Thank you.
Thank you, Pratap sir. That was a very colorful and very informative presentation. Now I would request Dr. Vinayak Patki sir to give his expert opinion.
Dr. Pratap has nicely talked about different scopies. Initially, he is mainly focused on upper GI scopy. Then he has mentioned about role of sedation, then technical aspects of upper GI scopy. Then he word about capsule endoscopy has mentioned, and bronchoscopy has mentioned about removal of foreign body. Yes, these are very nicely elaborated. Because of time constraint, I think he has restricted to only these two scopies. Scopies are coming in a big way in pediatric practice. Already this role has been quite nicely elaborated or widely used in ICU settings, but as far as general practice, pediatric practice is concerned, sinus endoscopy can be used for allergic rhinitis, blocks, then recurrent Blow's blocks, rule out polyposis and all those things. Lower GI scopy has already mentioned the details. This bronchoscopy flexible has a lot of other issues also. Doing when an unresolving pneumonia, you can go for a bronchoalveolar lavage, Vinibal. All these procedures can be diagnostic also, not only therapeutic. But both this rigid as well as fiber optic bronchoscope can be a way it helps you for a lot of differential things, especially with cystic fibrosis. You can go for directly culture for all those things. Then cystoscopy also has big role. The UV walls or all those things, removing the view reflex. A lot of other scopies are also there, and there are a lot of other interventional surgeries also coming in the scopies, like putting light, as already mentioned, like laparoscopy is coming in a big way, and minimal invasive surgery is replacing coming as a big way in pediatric surgery. So nice presentation, Dr. Pratap. Congratulations, and it was very nice to elaborated thing in a few minutes. Though it is a vast topic, conferences are done and workshops are done onto the scopies, but you have done a nice justice to your lecture. Thank you.
Thank you, sir. Thank you very much.
Over to you, Neeta ma'am.
Thank you, Neha. Our next speaker is Dr. Mahesh Bhatambre sir. Sir is consultant pediatrician. He is a director of Shri Anantapal Children's Hospital and Pathology Lab, Udgir, District Latur. We all know how important is the interpretation of a ABG in our clinical practices for the management part of the patient. Sir's topic is ABG analysis. Dr. Mahesh sir, please. Dr. Mahesh sir.
Yeah, yes, ma'am. Is it visible now?
Yes, sir.
Yes, go ahead. First of all, I would like to thank my IP team for giving this opportunity to me. This arterial blood gas analysis. Its importance of the ABG, which is must for all the patients on admission in ICU, or the like acute respiratory distress syndrome, severe sepsis, diabetic ketoacidosis, acute respiratory failure, asthma attack, inbornates of metabolism, for the ventilator planning, ventilatory settings, oxygenation plan, diagnosis of acid-base disorders, and diagnosis of dyslipidemia. We see the normal values of the ABG and VBGs. In the arterial blood, the pH is 7.35 to 7.45, that's in acidic, or in venous blood. PaO2 is 80 to 100 milligram of mercury, that's in venous blood is 35 to 40 milligram of mercury. PaCO2 is 35 to 45 milligram of mercury in arterial blood. Then main important is oxygen saturation, that is 97% in arterial blood, and venous blood is 70 to 75%, and basics is more in venous blood. In this, after in the ABGs, we first see the oxygenation, then we look for the stepwise approach to the acid-base disorders. In the oxygenation, we'll get the idea of the oxygen content of the blood, oxygen saturation, and important is alveolar to the arterial gradient. That's important to classify the respiratory failure, and derive will get the various indices. We'll see the steps in the analysis of the ABG. First and foremost is the consider the clinical settings to anticipate the disorder. What is the pH? That's a change. And then who is responsible? That's in metabolic acidosis, that bicarb responsible. In respiratory acidosis and alkalosis, that's carbon dioxide, PCO2. If the respiratory, that's which is acute or chronic, look for the metabolic compensation. If it is metabolic, then acidosis or alkalosis, how is the respiratory compensation and how is the anion gap, that is normal or increased, and is the more than one disorder is present, and we have to always correlate clinically. I have mentioned here one report. In these disorders of pH, that's in a metabolic acidosis, that there is a decrease in pH which is caused by decrease in bicarb, and in alkalosis, increased pH which is caused by increase in bicarb. In respiratory acidosis, there is decrease in pH which is caused by increase in PCO2, and in alkalosis there is a decrease in PCO2. There is in compensatory mechanisms, in if it's a primary disorders in metabolic acidosis and alkalosis, the pH changes in the blood and bicarb, this moves in same direction, and compensatory mechanisms by respiratory system. That's in acidosis there is decrease in PCO2 and alkalosis is increase in PCO2, and in respiratory acidosis alkalosis the pH and PCO2, this moves in opposite direction and compensated by renal system. As we have seen here, in pH, in acidemia, there is a decrease in bicarb, and there is metabolic acidosis and increased PCO2, that is respiratory acidosis. In metabolic acidosis, where there is a decrease in bicarb, there is a compensatory mechanism is if the PCO2 is if it is expected, then it is a simple metabolic acidosis. Then if the PCO2 is low, then it is a mixed metabolic acidosis, respiratory alkalosis. If the PCO2 is high, then it is a mixed metabolic acidosis with respiratory acidosis. In respiratory acidosis, where there is an increase in PCO2, that the compensation is by renal system, that's a bicarb. If the bicarb level is expected, then it is a simple respiratory acidosis. And if the bicarb is low, then it is a mixed respiratory acidosis with metabolic acidosis. And if the bicarb is high, then it is a mixed associated with respiratory acidosis and metabolic alkalosis. In alkalosis, there is a increase in either increase in bicarb or decrease in PCO2. If it is in a metabolic alkalosis, that is compensation is by respiratory system. If the PCO2 level is expected level, then it is a simple metabolic alkalosis. And if the PCO2 level is low, then it is associated with respiratory alkalosis. And if the PCO2 is high, then it is associated with respiratory acidosis. And in the respiratory alkalosis, where there is a decrease in PCO2, in that the compensatory mechanism is through the renal system. That's if the bicarb level is at expected level, then it is a simple respiratory alkalosis. If in the respiratory alkalosis, if the bicarb levels are high, then it is associated with metabolic alkalosis, and if the bicarb levels are low, then it is associated with metabolic acidosis. There are compensations are there in the various disorders, that expected compensation in metabolic acidosis and metabolic alkalosis. The compensation is through the respiratory system, that at appropriate level the PCO2, that is the PCO2 in the changes we will see in this case, in these cases. And in respiratory acidosis and respiratory alkalosis, in acute and chronic conditions, we see the compensatory changes by the increase and decrease in the bicarb levels. And in metabolic acidosis, important part is anion gap. We have to the anion gap, which is the difference between the measured cations, that's the sodium, and measured serum anion, that's the chloride and bicarbonate. Anion gap is also difference between the unmeasured cation, that's potassium, magnesium, and calcium, and unmeasured anions, that is albumin, phosphate, sulfate, and urate. That's normal anion gap is just 12, and the causes of increased anion gap are lactic acidosis, diabetic ketoacidosis, renal failure, and normal anion gap is seen in acute severe diarrhea, renal tubular acidosis. In these ABGs, first and foremost is very important that ensure the correctness of sampling and correctness of report. Look at the clinical profile and amount of oxygen being delivered. Avoid excess of heparin while collecting the ABG. No delay in processing. If so, it can be refrigerated for maximum 2 hours. Send the blood gases and electrolytes with bicarbonate if available. Serum bicarbonate and blood gas bicarbonate should be matching. My key message is respiratory monitoring helps in early diagnosis and gives guidelines towards the institution of the appropriate therapy. ABG is an integral part of the respiratory monitoring, and study of bedside clinical signs are much more important than excellent information provided by monitors. Thank you, ma'am.
Neeta ma'am, kindly unmute.
Sorry. Thank you, sir, for the excellent presentation on a very difficult topic. Dr. Patki, sir, your expert opinion, please.
It was nicely presented. ABG, though it is a very vast topic, he has covered. It is very difficult to conceptualize the things and present it in a short time. But he has presented all nice slides, and topic has been compensations. And the last important thing which what he has shown is the messages. The interpretation is now a lot of apps are there. You can go and start interpreting to that. Dr. Satish Dev Pujari has already made some apps, ABG, you can go and search that thing. So interpretation has become very easy. What we have learned in PGs and all that, this compensation rules and all that, it has become very easy now. But to interpret when to send, that is, and how to send this, yes, Dr. Mahesh has already mentioned, there should not, there are a lot of errors while collecting the samples. And delay in the sample, air bubble in the sample, extra heparin. These are so many things which we can rectify. Another point I want to highlight, other than what Mahesh has talked about, is ABG is not only for ICU settings. Very, very important. A lot of things can be diagnosed in your routine practice if your facility of ABG. There are two things why a general pediatrician avoids from ABG is, one is interpreting ABG. That's everybody feels is problematic. And other is the technique, because you start always you're pricking the artery here. So that is the problem why we want to avoid. So majority of the times ABG is done in institutes. For so many things like what he says, renal tubular acidosis, like child with the growth abnormality, not failure to thrive. So Bartter syndrome, Gentleman syndrome. So many things can be diagnosed, and those normal anion gap, high anion gap, like examples of if you are saying the poisoning cases. So anion gap also is there, and so if you start doing the ABGs and working on it and started interpreting, you get the fear of ABG goes away from mind, and it is a good tool as he's already mentioned. It has to go with the clinical settings. Unless and until you know the clinical settings, you cannot interpret the things properly. And you should know which are the parameters, which are only pH, PaO2, and PCO2. These are actually measured parameters. And rest all parameters are derived by the computer software. So this most important thing you should know. So nice presentation and nice message from Dr. Mahesh. Thank you very much.
Thank you, sir. Over to Dr. Neha, ma'am.
Yes. Thank you, Mahesh sir, and thank you, Vinayak sir. Our next presenter is Dr. Yogesh Salunke. He is MD Pediatrics, Assistant Professor at Government Medical College, Dhule. He was Secretary IIP Dhule in 2015-16. He has published papers in index journals. Today, his topic is ECG, why to do.
Hello.
Yes, sir.
Hello.
Yes, sir.
Good
Can you present it?
audible?
Yes.
Yes. Good evening, everyone. Is my screen visible, ma'am?
No.
Hello.
Your screen is visible, but presentation is
Yeah. The topic is given to me is to do. And in the topic there is a question. Is why to do. In the remaining slides, I hope we all get the answer why ECGs are to be done in a particular way. Without wasting time, I thank my IAP for giving me this opportunity, and I am beginning my presentation. Electrocardiography is nothing but the electrical impulse are generated in the heart, and there is a recording of the electrical impulse with the help of the electrodes. So why to do all these things in pediatric practice? We commonly do these congenital heart disease, cardiac arrhythmias, dyselectrolemia, syncope. Usually post cardiac surgery, we require serial ECGs, and of acute traumatic fever, ECG is mandatory. So why do ECG? It is all about to relate a graphical presentation and what is happening inside the body, like what is the P, QRS, T wave, and what is happening with the S node, AV node, and other things. So this is a normal morphology where you have a P wave, QRS complex, and T wave. T wave is nothing but the arterial depolarization. QRS is the ventricular polarization. ST segment, T wave are the repolarization part. Depolarization is followed by the contraction. So this is the ventricular and atrial complete the cardiac cycle. There is some differences between pediatric ECGs from the adult, so it is need to be mentioned before coming to the cases. So heart rate is faster in fibrillation, so the durations all are shorter, and there is a sinus arrhythmias, and there is a marked vagal tone. Again, the right ventricular is more dominant in a younger patient, so all these age appropriate things to be consulted before going for the ECGs. So ECG interpretation is with the rate, axis, intervals, PQRS complex, and T wave changes. The very most important thing that we have to read ECG in a clinical context and consider the age of the child. So after your historical examination, with your good clinical data, and then you go ahead with the ECG to interpret with the age of the child. Coming to the cases, I selected cases. You are of my own, you are from the literature. So you just old child who present with cyanosis on exam and history of squatting episodes with the saturation of 18, ejection systolic murmur, X-ray showing a decreased pulmonary plethora, and it is a case of a cyanotic heart disease. For echo, we have an ECG, and ECG is showing something like right ventricular dominance, right axis deviation, and echo turn out to be a case of a tautology of Fallot. So my take message is, look at the axis. If it is the right axis and it is decreased pulmonary blood flow, it is more of a tautology of Fallot with the right ventricular hypertrophy. QRS axis, normal axis is from -30 to 90, and there is something like right axis deviation and left axis deviation. So there is a mnemonic. If the first and the AVF leads are reaching to each other, then it is a right axis deviation. And if they are leaving, L for leaving and L for left axis deviation. I'm not going into the minor details, but I'm just sharing how to diagnose just looking at the ECG. Second case, this is a case of 4-month-old child who presented as a normal delivery, 3 kg child, but at 4 months also the baby has not gained the weight. And there is a frequent feeding difficulty and breathing difficulty. And because of the breathing difficulty, the child was admitted. X-ray was done showing cardiomegaly with pulmonary plethora. So suspected cardiac case, and we have done with the ECGs. Looking at the ECG looks fairly okay to me with the normal axis in this case. But with this normal axis, look at the precordial leads, mid-precordial leads. There is a biphasic QRS complexes, and it is called as the Katz-Wechsel phenomenon, and which is very commonly seen in case of VSD. VSDs are very common pediatric cardiac cases, and this phenomenon is consistently seen with VSDs. Similar case with the left axis deviation, and the picture turned out to be a case of AV canal defect. So looking at the axis, we can fairly call out that whether it is a what type of a septal defect it is. Next case, 5-year-old child who is asymptomatic but incidentally detected a murmur by a physician and referred to a pediatrician for opinion. So with the murmur, one X-ray and one ECG is a must. ECG is showing right axis deviation and some pulmonary plethora. It is found to be a case of ostium secundum ASD. So looking at just at the axis and X-ray correlation, we have diagnosed the case before the echo diagnosis is there. Similar case, if there is a left axis deviation, then it becomes a ostium primum ASD. So ostium secundum ASD is more common than primum, but just looking at the ECG with the axis, we have some diagnosis that it could be a ostium primum defect. Next case, 6-year-old child who was apparently asymptomatic till 2 days and history of syncope while playing. So most of the time in pediatric population, syncope has not been noticed or not been seen by the caretaker, and we have to collect the history from the who are the observer that what has happened. There is a history of cardiac death, and this is the ECG pattern. ECG, a normal QRS complex, some large T wave, but nothing significant. But so if you do not do something, you will miss the diagnosis. And this is the thing, that if you don't go for the QT interval and corrected QT interval, probably you miss a case of a long QT syndrome. This is a case of long QT syndrome with the QT interval more than 0.48. This is the formula for Bezet's formula for a corrected QT interval, that is QT upon root of RR. And corrected QT is to be considered. Normal values are 0.44 in infants and 0.49 in younger patients. But anything more than 0.47 is considered significant. Most common treatment is beta blocker and SOS pacemaker. They are more prone for sudden cardiac death also. So the relatives has to be informed about it, and they should avoid the competitive sports. 4-year-old child coming with uneasiness for 1 hour and brought to the casualty with the tachycardia. So for 4 years, 220 heart rate is significantly tachycardic, some soft systolic murmur. Immediately the casualty medical officer has done the ECG, and the ECG is showing this type of pattern. Just looking at the strip long lead 2, we are getting that there is a narrow complexes, and sometimes we do not find whether the P wave is there or not. But P wave is visible in case of sinus tachycardia, which is not visible in case of SVT. So this is a case of SVT, and we all know with SVT, with the tachycardia, with the clear pulse, then we have to go with the adenosine. Adenosine is given, adenosine is blocked and terminate the rhythm, and later on we have to find out after adenosine whether the rhythm has come to normalcy or not. That is also need to be checked, because 25% of the patients with SVT, they turn into the WPW syndrome like cases where there are delta waves are seen. So sometimes giving adenosine doesn't suffice. Post adenosine also we have to look for the ECGs. Next case, 10-year-old child was rushed to the NICU because some doctor has found different pattern of his cardiac activity. Child has some fine rashes all over the body and periorbital area, and severe bradycardia and poor peripheral pulses. Immediately the ECG was done in the emergency room, and this is the ECG pattern which shows bradycardia. And there is a dissociation between P and QRS complexes. These dots are the P waves, and the QRS, there is no association between P and QRS complex. So this is a case of complete heart block or 3rd degree heart block. Most common cause of bradycardia in children is because of this heart block or conduction defects. Coming to the heart blocks, there are 3 types of heart blocks, grade 1, 2, and 3. I am not going into the detail, and I will not say look at the heart block. So don't go to the type of heart block. If it is a heart block, documenting the heart block is more important than going to the type of the heart block. 6-year-old child coming with the puffiness of face, convulsion, cola-colored urine, and hypertension. So puffiness of face and cola-colored urine gives some renal etiology, but the child has convulsion and hypertension. There is a history of decreased urine output since 8 to 12 hours. As the patient is hypertensive, the ECG was ordered. The ECG is showing tall T waves, and this is a case of a hyperkalemia where the serum potassium later on came after 2 hours is 6.5. That is, sometimes the serum potassium level comes very late. So before the potassium levels are there, we had our ECG, and ECG showing hyperkalemia, and immediately the treatment for hyperkalemia started. So these are the normal pattern of hyperkalemia. Sometimes there are tall T waves to begin with. Later on the PR interval prolongs, and later on there is a sinusoidal pattern or a sine wave pattern. I think the last case, a 4-month-old child was very well for 15-20 days back, and there is a history of incessant crying and excessive irritability with some respiratory distress. Incessant crying in a 4-month-old child could be considered as colics. But in this case, the child has a respiratory distress, and the mother consistently gives the history that there is a poor feeding and difficulty and excessive sweating. So the child was admitted, and the X-ray was done. X-ray showing huge cardiomegaly. The child has poor pulses also. So huge cardiomegaly is a failing heart. So this is a case of congestive cardiac failure without a cause. we have done a ECG, and ECG are showing some pattern. These are called the deep Q waves. Deep Q waves are related with the ischemia. So this is ischemic heart, and the most common or the consistent cause of ischemia is found to be a Alka syndrome, where there is a left coronary is arising from the pulmonary artery. Without ligation, the child is not going to survive. The medical treatment is for the management of the CCF, the Lasix, fuel restriction, oxygenation, and all. And immediately is subjected to the surgical correction. It has a better and good outcome. So coming to the end, ECG convey the electrical health of the heart. Many times when the patient comes to the casualty, service is not immediately available. ECG is a quick, simple, and easily accessible and effective tool for diagnosing various cardiac conditions. ECG provides the important insight in the possible cardiac access. ECG should always be done in a suspected cardiac case, and pediatric ECG should always be interpreted based on the. Thank you. Thank you, ma'am.
Thank you, Yogesh sir. Now I request Dr. Vinayak.
Thank you, ma'am.
For your expert comments.
Very nice presentation. I think one of the finest presentation of today's webinar is this presentation. I really appreciate Dr. Yogesh for bringing these cases. Really nice. So many things he has put a light on it, and very crisp presentation. A few things actually in pediatric age group, ECG has become slowly becoming out of our investigations because easily availability of the echo. And that's why so many things we try to diagnose on echo, and that's why our classical PG teaching of do X-ray, do the ECG, try to get the diagnosis of any congenital rheumatic heart disease, and then confirm your diagnosis by echo. That was what teaching to us. But now it has becoming reverse medicine. Just put the stato, get the murmur, and send the echo, and then confirming that you start doing ECG. This slight note apart, but so many things we can diagnose. Congenital heart disease can be diagnosed as specifically tricuspid atresia. Like this is the only condition which have left axis deviation. Classical Himalayan T waves, this is you get in Epstein anomaly, what you get. Then SVT, as already is mentioned, only not only rate, but he has to be diagnosed. Sometimes it is difficult to differentiate, but ECG, if you are it is there in house, go for diagnosis. Prolonged QTC that can be congenital or acquired. Congenital can be a Dylan syndrome is there, where you can have family deaths and all. And acquired maybe because of hypokalemia or hypocalcemia, and lastly because your hydroxychloroquine, what we have used in and out in your COVID, that also can cause this kind of prolonged QTC. So this is the important investigation as far as your syncopes are concerned. Then coming to hypo and hyperkalemia. So principle is never treat your potassium levels only on lab level. You have to always treat the ECG changes. So this is something what we can extra points which I can add on this presentation very nicely. Thank you very much for.
Yogesh sir, kindly stop your share screen. Yes, sir. Thank you, sir. Neeta ma'am.
Thank you, Maha-IP and Women's Committee for giving me this opportunity, being coordinator for the today's program. And thank you, Neha ma'am. Thank you.
Dr. Jay sir want to speak, sir. Please, can you?
Yes, ma'am. I will acknowledge him.
Yeah.
Most of the times we pediatricians choose for clinical diagnosis without investigation. But as after any crime, the police does thorough investigation of crime. Same here. Many times we too need, as detectives need to do investigations. We to get the root cause of the disease or problem. And today's program has definitely enlightened us about many of the important investigations. So now I request Dr. Jay Bhandarkar sir for the vote of thanks.
Thank you. Thank you. Yes, I think I am audible now.
Yes, sir. Yes, sir.
Thank you, sir. Thank you. At the outset, I thank Dr. Vinayak Patki sir and Dr. Sudhir Sane. Done an excellent job as an expert and spared their time for this our Maha-IP. And what to say about our presenter, Dr. Vaibhav Barot from Palghar, Dr. Abhij Joshi from Aurangabad, Ramarjit Wag from Nagpur, and Pratap Patel from Ahmednagar, and Mahesh Bhatamare from Udgir, and Dr. Yogesh Shalunki for Dhule. They presented very well. Thanks for preparing well. And I know all topics are very, very important, and covering within 6 to 10 minutes is so difficult. And thanks all of them for giving their this I can say very lucid topic and very important information in a short time. And thanks to our both I think MOCs, Dr. Neha Singh and Dr. Nidhatkar Madam for doing excellent job. And thank you to this Maha-IP Women Wing led by Dr. Renu Boralkar Madam, and doing excellent job for academic sessions for Maha-IP. Though we talk about the every Friday of Maha-IP, but the Tuesday talk is the excellent one. And thank you. And thank you all the audience and delegates on the YouTube and Zoom for attending in large number. And all your the senior pediatricians as well as juniors attending these sessions. And thank you, Maha IP, from myself for that's doing wonderful job. And now we are end of year and thinking something more, doing something for last 1 to 2 months. So thank you very much, all of you, for giving this time and doing wonderful job. Dhanyawad. Good night. And thank you, Pallavi Madam, Dharmadhikari, for doing this digital work, and as well as Dr. Vishal, all these posters and other things. Thank you.
Yeah, we thank you, Dr. Jay Bhandarkar, sir, for giving the vote of thanks also, and as a convener of this program. And also, we will be meeting for the 9 Tuesday talks on 18th October at the same time next month. So please do join for it. Over to you, Neha.
Yes, ma'am. Thank you, ma'am. Pallavi, ma'am.
Yes, ma'am. Yes, ma'am.
Yes, please stop.
Yes, ma'am.